All right, slides are up on our end, ready to share.
So I think we should start
right.
our session. So good morning from Nepal. So we have participants from different countries. So we are really happy to be with you and share the experiences in rural health and telemedicine. So I would like to start this introduction. I am Dr. Uday Koirala, working as a senior consultant surgeon in Kathmandu Model Hospital. I've been working in rural health and telemedicine. I'm also a deputy director of this Center for Rural Health and Telemedicine in Sept, Nepal. I've been working in telemedicine for the last 10 years and also in rural healthcare. So I would like to start our introduction. So I would like to invite Dr. Good to introduce yourself. You're mute. You are muted. So microphone. Yeah. Dr. Good.
Is the voice good?
Yeah. Now yes.
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 Good. I'll introduce myself. I'm Dr. Jim Good. I'm an intensivist and pulmonologist. I'm a professor of medicine at the University of California, San Francisco. I'm the medical director of offsite care, global offsite care. And we were in Kathmandu last November and had a wonderful experience with 6 hospitals. Thank you.
Thank you. Thank you, Dr. Good. So I'd like to invite Professor Chiang from Taiwan.
Hi, this is TMSoN Jiang from National Taiwan University. It's glad to join this session. Thank you very much.
Thank you. Michael Cook from USA, Global Telemedicine.
Hello, I'm president of Global Offsite Care. I'm a computer guy, not really a doctor, but I support Dr. Good and work with him closely, and I'll be on his slides tonight. Glad to be there.
Thank you. Dr. Dennis from Philippines.
Yes, good morning or good noon to everyone. This is Dr. Dennis Batangan. I'm with the Ateneo de Manila University in Quezon City, and I also work as the Senior Technical Specialist for the Prosperity Fund Better Health Program of the Foreign Commonwealth Office of UK in the Philippines. Good morning, everyone.
Thank you. Dr. Prakash from Nepal National Hospital.
Hello, namaste. Myself, Dr. Prakash Bordal. I'm a physician, I'm pulmonologist and critical care expert at Nepal National Hospital, and I've been into telemedicine since last 2 years. That is, thank you.
Thank you. Here is Mr. Atit Koirala from Myanmar.
Hi, good morning. My name is Atit. I work for a company called OnDoctor. We are a for-profit private company providing telehealth, teleconsultation in Myanmar. Thank you. Glad to be here.
Thank you. Dr. Roger Strasser, now in New Zealand.
Yes.
Yes.
Hello, everybody. My name is Roger Strasser. My background is as a rural family doctor, general practitioner in Australia, and I was the first professor of rural health in Australia in 1992. Between 2002 and last year, I was the founding dean and CEO of the Northern Ontario School of Medicine in Canada. And right now I'm professor of rural health for the University of Waikato in New Zealand.
Thank you. So there is Khesar Gyalpo University from Bhutan. Your microphone is muted. Please unmute your microphone. Yes, please introduce yourself.
Okay, I'm Srin Samdru from Bhutan. working as ICT officer, and then we have now intern and resident as well. And then shortly, our lecturers and professor will join us. And then I think we will have a fruitful day today. Thank you.
Thank you. Here is Shintaro from TMDEC.
Okay, hello, this is Shintaro from Tendai Kyushu University Hospital, Japan. Nice to see you all, and I hope this session will be a fruitful one. Thank you.
Thank you. Rojan from Model Hospital.
Hello everyone, I'm Rojan Sai from Kathmandu Model Hospital, and I'm the chief engineer for this session. Thank you.
Thank you. Dr. Kavin Bhattachan is gynecologist and also interested in telemedicine. Dr. Kavin.
Hello, good morning, everyone from Nepal. I'm Dr. Kavin Bhattachan. I am consultant gynecologist working in the Kathmandu Model Hospital and partly also related to telemedicine, rural telemedicine in Nepal, and with Dr. Uday Khorela. Thank you.
Thank you. Thank you. Nirajan from Nepal Research Education Network.
Hello, everyone. I'm Nirajan Purajoli. I am a chief engineer of Rural Healthcare Session. Thank you.
Dr. Vijay.
Respected personalities, good morning, everybody. And I'm a resident in general surgery in Kathmandu Model Hospital, and feeling grateful to join this session. Thank you very much.
Dr. Sushil.
Hello, namaste. I'm Dr. Sushil from general surgery and now posted in Kathmandu Model Hospital. And I have experience of working in rural areas of around 4 years. Now I'm a surgical resident. Okay.
Thank you. Yoriko Nishizawa.
Good morning, everyone. Dr. Yoriko Nishizawa. I'm a neonatologist working in Kesalgyap University of Medical Science of Bhutan. Nice to meet you. Happy to be here.
Thank you. Pradeep Kumar Chaudhary.
Hello everyone, this is Pradeep Kumar Chaudhary, Deputy Manager of National Medical. I newly joined National Medical College. Thank you.
Thank you. There is another KMS resident.
Good morning, everyone. This is Dr. Manik. I'm general surgery resident at Kathmandu Model Hospital.
Okay, thank you. Thank you, everyone. So actually, we had also invited our guest from Indian Telemedicine Society. So I think he couldn't attend. He is busy. Professor Dhital, who is also chief of surgery in Model Hospital and also director of rural healthcare and telemedicine, he also couldn't attend this meeting because of his busy schedule. So he had said hello to everyone. So I would like to start the presentation since Ashwin is not here. So I would like to request Dr. Dennis to start your presentation. Thank you.
So
Thank you very much.
I will control your slides, sir.
Yes, yes. Thank you very much. Thank you very much, Roger. Good noon to everyone. Greetings from the Philippines, and thank you for the invitation to present. And we've gone a long way with Dr. TC and Dr. Dhital since we first sort of met in Korea in Chunbuk, a few years back, and we sort of maintained connections also through these rural healthcare sessions in AFAN. The topic that I propose to discuss is actually more on the e-health or e-learning side. It's entitled Technology-Enabled Healthcare System, Creating E-Learning Spaces in a Pandemic Environment. So I represent the Institute of Philippine Culture at the School of Social Sciences in the Ateneo de Manila University in the Philippines. This is actually a project also of the Department of Science and Technology, Philippine Council for Health Research and Development. So you see the logos of the respective institutions at the bottom of this slide. Next slide, please. So the outline for the outline for the presentation includes, of course, we could not disregard the context that we are in now, which is the COVID-19. And then I'll go into the universal healthcare context in the Philippines, including the health information system requirements of the law, and then move into the National Unified Health Research Agenda, for which this work has been lodged on, and the work that we're doing specifically on e-learning called the E2 Weekend series, which is actually a support to the frontliners, to the health workers here in the Philippines through e-learning, used with the use of technology platforms. Next, please, Arjen. So after the pandemic broke sometime in the first quarter of this year, we've been sort of bombarded with these types of graphs and the different situations that we are in. So this is a sort of a graph from, I think this was in May, on how the cases in the Philippines was increasing drastically. But what I would like to point out as well was during that time, also in the Philippines, we were actually preparing for a universal healthcare implementation, and this was disrupted actually by the COVID-19 pandemic. And we had to go through what we call here in the Philippines GCQ. GCQ means General Community Quarantine. That term has evolved into extreme or enhanced community quarantine, and now there is still versions of what they call extreme community quarantine. Next slide, please. So the Philippines is a developing country of around 100 million Filipinos, 7,100 islands. It's in Southeast Asia. It's a member of the Association of Southeast Asian Nations. And in 2019, we passed a law called the Universal Healthcare Law. And a big part of that particular law was focused on e-health, which actually was focused more on the recording and reporting system. But it includes also the e-learning component, because as the Department of Science and Technology head was telling us, we need to catch up actually with the technologies that are being introduced to our health workers. So we also need to use technology to be able to capacitate our health workers. Next slide, please. And this is the complicated design actually of the Universal Healthcare Provider Network that was implemented or still being prepared for implementation in the Philippines. What I would like to highlight is on the left, the cloud, is that the service delivery and capacity building component will be reliant to a certain extent, to a large extent, to information, communication, and technology and e-health. So this actually shows the referral mechanisms from the gatekeeping at the community side and the role of private and public sectors, and the referral process going through the going to the secondary and to the what they call the apex hospitals. And all of these are planned to be connected through ICT or information communication technology. Next slide, please. To support that particular initiative, Universal Healthcare, the government also updated its National Health Research Agenda, which is part of the National Harmonized R&D or Research and Development Agenda. And you see here in the red dot that health is just one component of the Harmonized Research Development Agenda. And the health part is actually articulated more clearly in what is called the National Health Research Agenda, which includes ICT and health. And the work that we're doing is actually lodged in that ICT and health component, which is actually being managed by the Philippine Council for Health Research and Development. But all other agencies in the Philippines relating to health research have actually converged under the Philippine National Health Research System. Next slide, please. And the approach for sort of blending or weaving universal healthcare and techno-governance is through the techno-governance approach, which means that we'll have to look at policies, e-health policies and guidelines that should be consistent or should be supportive of the process flows, no, in the delivery of health services. And of course, there should be some capacity building, no, which could also use technologies to be able for our health workers to be able to adapt and use these technical solutions for the identified gaps in the delivery of health services. Next slide, please. And for our part, the eTuro or project, which is actually a webinar, it started as a webinar series, it still is a webinar series. When the universal healthcare came into fore, we sort of started a series of discussions on universal healthcare. So you'll see here a series of webinars which we co-hosted, no, with the Philippine Health Insurance Corporation and some other partners, including issues on the core values of universal healthcare, which is patient rights and human rights, no? And of course, health financing and health informatics. The picture you see at the bottom is actually one of the last live webinars in the university that we did, of which we had the resource persons in one location. When the COVID pandemic actually struck, we had to do all the webinars all by remote, no? Because we could not, the university was closed, we could not go to the university premises. Our resource persons also would prefer that they do it at home or in their secured locations. So we did everything now by remote. Next slide, please. And this was some of the last or the what we call transition webinars that we had during the last few. I think this was last week of June and early July. So what we did was to sort of shifted the discussions away from a purely COVID pandemic discussion to a more systems-oriented discussion, looking at primary healthcare and universal healthcare. So we had two successive webinars. One was with Dr. Susan Rifkin from University of Colorado, and also previously and also now Johns Hopkins, no? And Dr. Mary Rosselli, the research scientist from our university, with our director, Dr. Lau, as the moderator. Another one with Dr. So, former WHO country rep, and Dr. Madeline Valera, also of the Philippines, with Jesse Claudio as the moderator. But what we sort of tried to do, and we're actually in this shifted phase now, we are actually moving, or we are having now webinars along the context of universal healthcare, but still touching on the issues related to the pandemic. Next slide, please. And this is the last slide. Actually, just want to show that with the series of webinars that we started in February 13, 2020, these are the numbers of participants, no, pre-registered participants, and the actual numbers, no. So over the series of around 18 webinars, there were around 33,162 webinar registrants, no, but not all of them actually attended the webinar. Only 24,143 were live attendees. But what we have noted actually is that there was an interest actually to participate in these webinars. And some of these actually are regulars. No? They've been attending regularly the webinars. And we've also sort of reached to some other ASEAN and other countries. And at this point, actually, I will be extending the invitation to those who are participating in this APAN conference to our webinars, no, in the coming months, no? And we will be sending the information through APAN, because we also see the value of collaborating and discussing things across common issues, even across borders. We noted that people would want to hear and would want to know what's happening in different parts of the country, and even in other parts of the world. We also started a series on ASEAN, of which we sort of had updates, no, on what was happening in Thailand, Malaysia, Indonesia, and Vietnam, and of course the Philippines. So across those 5 countries, we've seen some similarities. We've seen some differences as well. But what was important that we noted was there was a common interest to communicate, to understand each other, and to be able to share things, and be able to also be in solidarity with other ASEAN neighboring countries as we all go through this pandemic, which up to now we still don't know how it will end. I think that was the last slide. Next slide is actually the last slide. I'd like to thank you again for the opportunity to present this. And if there are any questions, I'll be happy to take them later. Good morning again.
Thank you, Dr. Dennis. So if there are any questions to Dr. Dennis, please, the floor is open. Anyone? So if there are no questions, then I would like to invite Dr. Roger to start your presentation.
That's me? Are you asking me?
Yes.
Yes, okay. So am I sharing my slides from my computer, or are they being shown from?
I think, yeah, you can share. You can share from
I'll
your
share
side.
my slides here. That's what we did in the practice session. So I'm happy to do that again. Let me just organize that. Share screen. Okay, you're seeing my slides, my first slide? Yes, no?
Yes.
It's working. Okay, good. All right. So thank you very much, Dr. Corella, for the invitation and the opportunity to be part of this very exciting seminar today and part of this larger APAN 50 conference. As you can see from the title slide, my topic is rural health and looking at telemedicine and rural health in the COVID world. I'm going to say a little bit more about me before then describing rural health, talking about telemedicine or information communication technology and the implications of the current COVID pandemic. So as I mentioned earlier, my background is as a rural general practitioner, family doctor in Australia, and I was the first professor of rural health in Australia, starting in 1992. And then in 2002, I moved to Canada and joined others in establishing the Northern Ontario School of Medicine, where I was the founding dean and CEO until last year. And right through, I've had an international role. I was the inaugural chair of the Working Party on Rural Practice for WONCA, the World Organization of Family Doctors. And I'm now actually in New Zealand as the professor of rural health at the University of Waikato. So I bring a global perspective in some ways and some specific experience in different countries. And I want to talk now about rural health. So the very first World Rural Health Conference was held in 1996 in China. And we had over 300 rural practitioners from many different countries, 30 plus different countries, and very different countries in terms of their geography, the population distribution, the level of development, the climate. It's hard to imagine how they could have been more different from each other. So it was a real surprise for us to find that we had so much in common and that the major issues in rural health are the same around the world. Access is the rural health issue. Even in countries where most of the people live in rural areas, the resources are concentrated in the cities. There are always communication and transportation difficulties from one rural community to another and between the rural and the urban centres, and there are never enough providers of healthcare, doctors, nurses, community health workers, and others. So let's talk about health services in rural communities. Nearly 30 years ago, I did some research looking at the health needs of small rural communities and realized that a major preoccupation for people in rural communities is what I call a safety net. And I soon realized that actually people are the same everywhere. They have a security need. They need to know that if they're unlucky enough to be seriously ill or injured, the system is there, in quotes, to save them. Now, in the big cities, there are hospital emergency departments and ambulances, and And essentially, people know that safety net is there. But in rural communities, that can't be taken for granted. And so there's a preoccupation with having a doctor and a hospital and other local health services. And people really prefer to be looked after, provided with high quality healthcare close to home in rural communities. It's very clear that if you take a model of a health service delivery from an urban setting and try and somehow adapt it and modify it and put it into a rural setting, it generally doesn't work. The health services that work best in rural communities are the ones that are developed in the community, by the community, for the community. So let's talk about the healthcare providers in rural communities, the rural practitioners. They really can be described as extended generalists. So compared to their metropolitan counterparts, rural practitioners provide a wider range of services that carry a higher level of clinical responsibility in relative professional isolation. And that's true if you're talking about family physician general practitioners, if you're talking about surgeons or pediatricians, any of the specialties in medicine, but it's also true talking about nurses and nurse practitioners and about pharmacists and physiotherapists. Rural practitioners are extended generalists. And generally, rural practitioners live in the community that they serve, and so they have the opportunity to affect the health of the whole community at a community level. And I would say probably the best example I know of this is the rural doctor in a small inland community in South Australia, who was so effective in telling the story about the connection between red meat, cholesterol, and heart disease that the butcher shop started selling fish. One of the major issues for people living in remote and rural communities is access to specialist services. Generally, the specialists and the specialist service providers are concentrated in large acute hospitals, health services in the big cities, and so a long way away with lots of the challenges that I've described in terms of communication and transportation. But there's another issue, and that is about the attitude, the approach that the specialists have. Most of those specialists have never really had any experience of living in rural communities and not an understanding of the rural context. And so the common response when asked about a patient by the local doctor in a rural community, well, just send the patient in. It doesn't fly. It makes no sense. It's unreasonable, unrealistic, and impractical. The issue is people need to have high quality healthcare close to home, and they prefer to be looked after by people they know. So the local providers of care, the community health workers, the nurses, the doctors, the administrators, they are the frontline providers of care. And the role of specialists is to support those frontline providers of care, to really provide support, assistance, and guidance so that people do have high quality health care close to home and only need to travel to access specialist care when there's something specific about that care. So let's move now on to information communication technology. I've chosen that term rather than telemedicine to demonstrate that there are many different forms and shapes, and in some people's minds, telemedicine means one thing and not another. There's informatics, e-health. The previous presenter talked about e-health. Really, it's about any kind of information communication technology in any form, whether it's text, audio, video, e-health records, real-time, asynchronous, and so on. And there is huge potential for ICT to enhance rural healthcare. Examples in real time, intensive care specialists supporting rural emergency departments, asynchronously doctors or nurses taking pictures of skin rashes and sending them to dermatologists for an opinion, even supporting people at home, people keeping a record of their blood pressure and their pulse and other signs that then can be sent as a text message to their clinic and to get advice that way. So a lot of potential with information communication technology for rural communities, and the leapfrogging of the technology, the mobile phone network, satellite, and so on. So not having to go through copper wire and fiber and so on, but straight to the wireless technologies really opens up great possibilities and huge potential for enhancing rural healthcare. A particularly important example of this I wanted to talk about, which is Project ECHO. As you can see, ECHO is an acronym. It stands for Extension of Community Healthcare Outcomes. And this model was developed in New Mexico, the state of the United States called New Mexico, which is a very rural state. There's one large city, which is Albuquerque, and all the other communities are rural communities. And Albuquerque at the time had one hepatologist, one specialist who looked after liver disease. And when there came a treatment, a cure for hepatitis C, there was no chance that this one hepatologist could actually treat everybody with hepatitis C infection right across New Mexico. So he developed this model of real-time video conference networking with healthcare providers in the rural communities. And so the local clinicians come join the video conference, talk about their patients and receive advice and support and guidance so they can provide high quality care close to home for the people in the rural communities. This model of Project ECHO has been replicated with different health problems and diseases and in many, many different countries around the world. And I think it is an example of the potential great value of information communication technology to enhance rural healthcare. So I mentioned the World Organization of Family Doctors, which is otherwise known as WONCA, and I was the inaugural chair of the Working Party in Rural Practice. And at that first conference in China, or in fact, the second conference that we had, which is in South Africa, there was a lot of discussion about communication technology, which was just the coming thing at that time. But there was a real problem. We talked about the upsides and the downsides. And a major downside was that the technology enthusiasts in the big cities were kind of persuading the politicians to think that if they paid for communication technology, they wouldn't have to invest in people and clinics and healthcare in rural communities, a kind of substitution. And so unfortunately, there were examples where the funding was provided and the equipment was sent to the rural communities. And sometimes somebody opened the box and maybe even set up the equipment, maybe even had some idea how to operate it until it broke down. And of course, they couldn't fix it. So in this context, we developed this policy first in 1998. It's been updated since then. And the key elements of this are really that to get the best value out of information communication technology, the local people, the local healthcare providers, administrators, community members, they have to be in charge. They have to make the decisions about which technology and how to use it and when to use it. And that the funding should really be an investment in people and expertise in technology capacity, and of course equipment, but equipment isn't first, it's actually the enabling step really. And so that's how ICT can be a catalyst to healthcare in rural communities. I arrived in Northern Ontario, excuse me, I arrived in Northern Ontario in 2002, and I found there what was then called North Network and became Ontario Telemedicine Network. And they had never seen the policy, but they were doing everything that was in the policy. And it was very successful. Real-time video conference connection between specialists and patients, saving literally thousands of dollars in terms of costs of transportation and other costs so that people could access specialist care without having to travel. And it worked. Yes, the technological aspects were important, but it worked really because there was a reliable scheduling system and ongoing communication where the clinical leads in each community, the nurses who were in charge in each communities, they really made the decisions about developing and enhancing and adding to the value of the Ontario Telemedicine Service. So let's talk about COVID-19 pandemic. The previous speaker spoke a lot about that situation in the Philippines. I would say as a general statement, looking at different countries around the world, that the experience of COVID-19 really has brought into sharp focus the inequities, the disparities, the problems that were already there, and in particular for rural communities, the limited resources and access to healthcare, even to the point of community leaders in rural communities saying to people in the city, stay in the city. You can't escape the virus by coming to our rural community. We don't have enough capacity to look after our own people if they get sick, let alone outsiders. Another theme that's emerged from the COVID pandemic experience is about self-sufficiency and self-reliance. Of course, Initially, it was about ventilators and personal protective equipment, but it's moved on to food security and about the capacity of local personnel to actually manage the situation at a local level. And in fact, I would say that I'm seeing more and more examples, more stories really about the importance, excuse me, the importance of that local capacity where the local business leaders and community leaders, they discover that there's been a COVID positive visitor to town, and they immediately close things down. They immediately organize testing. They immediately take precautions long before the health authorities in the big city have even noticed that this has happened and actually been in contact. And so I think the big message out of the COVID-19 experience is the importance of developing local capacity and having the capacity to deal with a crisis, whether it's the next wave of the pandemic or something else, locally. And so protect the high cost, high technology services that for some people will be needed in the big cities. So I've just fairly quickly given you an overview of rural health. I've talked about telemedicine, information communication technology, and the current experience with the COVID pandemic. Like in conclusion, I would say that information communication technology, telemedicine, really is or could be a game changer and really make a difference for healthcare in rural communities, especially in this COVID world. But to actually achieve that game changer status, you need to start at the local level with partnerships with local communities to address the local healthcare needs towards achieving the ultimate goal, which is health equity. That concludes my presentation. My slides were circulated before, and there are some references for those who'd like to follow that up. But I'd be very happy to respond to any questions or comments at this time.
Yes, thank you, Dr. Roger. It was a nice presentation. So, are there any questions to Dr. Roger? So, actually, I was very much impressed by your work in rural health, because Nepal mainly has these type of rural places, so many, and retaining health care workers in rural part is a big challenge. So what is your advice for the retaining of healthcare worker in rural places?
Yes, thank you. I have only been to Nepal once, and on now several occasions I've nearly made it again, but not yet. Maybe next time I will make it there. And you're absolutely right. I think Nepal is a country where all of the challenges of rural health really are in your face, where as soon as you leave Kathmandu and you're into the other communities and so on. I would say the real, it's a series, like there's no one single intervention. If you do this, then everything will be resolved, okay? If we'd found that king hit solution, it would have been done years ago. So it's not just one thing, it's a series of interventions which each make some difference that add to a complete effect. So the first is about who actually you choose to train to work in rural communities as healthcare providers. And the people who live in those communities know those communities. The idea of living and working in those communities is attractive to them. They have family there and that sort of thing. So the first is to recruit students from the rural and underserved communities, and then provide them with their education and training predominantly in those community settings. So the standard model for medicine, nursing, and others, of course, is in the big city teaching hospital, which is a very different context. But if you want your graduates to have the skills and be prepared to provide care in the rural and remote underserved communities, then they need to have clinical experience in those settings, and they need to have the local healthcare providers as their role models and mentors, because then they can see themselves becoming rural practitioners. And you need then training that prepares the graduates to practice in that setting. I was impressed when I was in Nepal with the MDGP program, which is that kind of rural-based training program for GPs, and prepares those doctors to work in the hospitals in the rural communities in Nepal. But that's just the education and training part. Then you've got to actually persuade those healthcare providers and their families that this is the right place for them to live and to raise a family and so on. And so there's an important role for the community. Active community participation or community engagement really is essential in ensuring that when they're there as students and as trainees or residents, and then looking at coming to a community, that the community makes the healthcare provider and the family feel welcome and want to be part of the community. And so there are issues about employment and other activities for a spouse, education for the children, other factors to be taken into account to make it attractive and supportive and welcoming. Of course, there has to be some basics like a safe and supportive work environment, so a cohesive team to be a part of in terms of the care that you provide. And we're able to talk today because of broadband high-speed internet. So broadband high-speed internet, I would say, is an essential requirement now for providing healthcare in any community, in any rural community in Nepal and in any country, in fact. I would say also that the members of the health team in the rural setting, they need to be supported to work as a team and to keep up to date. So continuous professional development that helps those them to develop as a team and at the local level, but also using the online or distance education means to keep up to date and to support them to travel to access continuing professional development where that's relevant, so they really are supported to keep up to date. And I think it's important for them to see a career pathway ahead of them. So the opportunity for further study, maybe graduate diploma, masters, again, by distance education, so they don't have to travel to the city. They can pursue the higher education and progress their career while staying in the rural community setting. And if you put that package together, then all of those interventions come together and bring success in recruitment, retention, and essentially having a stable rural health workforce.
Thank you, Dr. Rosa. Here is Professor Shimizu from Kyushu University. Sorry, can you please introduce and say hello to us?
Okay, thank you very much. It's quite nice to see you all here in the rural healthcare session, and thank you very much for organizing that nice program. And it is a very impressive presentation, and we're also familiar with the ECHO program. And I believe that it is a very nice, initiative and a nice, program too. So I'm happy that Dr. Roger Strasser has been working hard for the, telemedicine. I mean, the rural health, telehealth there. So thank you very much again for everything. Thank you.
Thank you. So next, I would like to invite Dr. Good to have your presentation, sir. Your microphone is
sharing the slides, and I'll do a little short intro. Let's see, host needs to enable participant screen sharing. It says here. Uh-oh. I sent you the link. Maybe you want to show the slides because I'm disabled. It says host disabled participant screen sharing.
I can proceed without slides. The slides are fine if they come on. If not, I'll proceed.
Okay, but I wanted to provide the context of global offsite care, just a 30-second intro to say we're an all-volunteer organization, a grassroots kind of organization. And we've been working primarily through Rotary clubs in Asia and in Africa. And we have three primary modes. One is the continuing medical education, another is teleconsults, and the third is electronic medical record that we hope to provide in the future. And what Dr. Gu's prepared to do is give you an example of a topic that was presented recently in Grand Rounds, which is the continuing medical education. So Dr. Good?
Yes, first of all, thank you for the opportunity of talking. I enjoyed very much hearing what's been happening in the Philippines. We worked in the Mary Johnson Hospital in the Philippines, and very much in terms of Canada, Australia, in terms of Dr. Strasser, just very imaginative work. I enjoyed that. I'm going to give you a lecture without slides now because our slides aren't going on, but my old professor used to say, if you can say it without slides, do so. I'm going to do it without slides. We do three things in global offsite care. We got together approximately 7 years ago, and this is an organization of Rotary individuals, because Rotary is the machine behind us. You need to have some source of support, of finances, and of world presence. Rotary has over 30,000 clubs in the world, and they are our network we were through. We're in 20 hospitals in the world right now. And each of you have given your, I'm going to say, prescription with telemedicine to try to help world health. I'm going to give you our prescription. And this prescription comes from years of medical practice, being a professor, and then facing, as I'm older, what can be done on a larger scale away from my city, from my state, from my country, namely multinational in terms of a global approach. And the other two professors described telemedicine as a game breaker, and it is. Let me give you an example. By the way, COVID-19 is more a problem in developed countries than in undeveloped. In the United States, we have 5 million cases, we have 150,000 deaths, and we have the highest, if you will, disease with COVID-19 anywhere in the world. Part of it is our lifestyle. It's very open. It's hard to get people to follow the regulations they have. Part of it is the virus that's got to start here. But put it all together, we have a major pandemic here. Now, in terms of what I would give to you as examples of how telemedicine can help the world, I think there are three ways. One is behind me. You can see this right here. This is my office right now. By the way, I'm near San Francisco. This is a telemedicine consultation unit. It costs less than $1,000. It has a unit on here that's called a Kubi. With a Kubi, from anywhere in the world, I can turn that and make this cheap Android pad, this is Samsung pad, act as a robot to see patients, so that with this unit, a hospital, and we deal with the unit of the hospital, has a mechanism to get consultations from their own panel. They should set up a panel in the same language, same culture, same pharmacy, same economic restrictions, same culture in terms of life and death. And their panel, and the hospital is really the unit we work in, can be enriched by asking consultations via this unit. We call it a Kubi unit. This Kubi, which is the device that turns, is made nearby here in a city called Petaluma. Of course, this is made in Japan. The unit, we have a unit that's a speaker. We have a microphone. This enables a hospital to get consultations. They can get them rural, local. We're usually dealing with hospitals in rural settings. They can ask us to come in. This morning, Dr. Prakesh, who's part of the presenters, called me because they have a patient in the National Nepal Hospital in Kathmandu with a problem requiring consultation. We have a panel available of San Francisco intensivists who will consult on cases if they need it. But remember, I'm a coach. I'm helping them do what they do. I'm not doing it for them. So with Dr. Prakesh, we have this arrangement of doing consultations if his local panel would like another opinion. We're no better, we're just giving a different opinion. and we have the different armamentarium, if you will. But the first thesis that we have rotary backed, we're in about 20 hospitals right now, is that when we go in a hospital, we give them this unit, plus we give them a large screen with an international microphone, plus a computer, so they can partake in weekly rounds. On these weekly rounds, we try to emphasize cases they present. We have cases presented from Nigeria, from the Yanagwa Hospital, from Rwanda, from the Kabale Hospital, that's Uganda, pardon me, from Rwanda, the Shira Hospital, from the Congo, the Kolwezi Hospital, from Zimbabwe, the Christian Hospital. We've had patients presented from Mary Johnson Hospital in the Philippines, from China, from the Fudan University, from India, Northern India, from Nepal. We're in 20 places. We'd like to be in 200 or 2,000, if really the technology will allow us. And remember, we make an initial investment, giving this equipment to the hospital, funded mainly by Rotary and by our raising funds, if you will. And we're entirely 501c3. No one gets any salary. The travel we have is paid for not by any funds that we get. It's paid for by getting a grant from International Rotary. But the first thing we do is to try to arm that hospital with the ability to get consultations. As it was mentioned in the talk of Dr. Strasser, in terms of getting consultants from the city to go to the rural aspect, can be done with this. But this gives any one of our hospitals the ability to do consultations. And again, if necessary, they can call upon us in the San Francisco area and we will do such. We have a lot of experience with COVID. For example, generally, I'll be seeing by telemedicine upwards of 10 COVID patients a day. And this is in ICUs around California, Oregon, Washington, and so on. So we have a lot of experience in terms of seeing COVID patients. But the first point I make regarding global offsite care is consultation. We coach them so they've got the means, this apparatus, and also the availability of their own consultation panel, and they can call upon my consultation panel in the United States in addition if necessary. Usually they don't, but they may. So number one is consultation. Number two is education, and I believe very much in education. We right now present every Wednesday a case of COVID that's presented with a particular problem. Like yesterday, we talked about convalescent plasma. What's the data regarding convalescent plasma? How easy it is to obtain. The United States has used about 50,000 units of convalescent plasma. It's being used more in the world. There's no study right now that really shows a mortality improvement. There are studies that show morbidity improvement, less illness, if you will. We had a lecture yesterday by a professor from Yale who talked about not only antibodies that are in the convalescent plasma, but exomes. These are new materials you may not have heard, but they have a lot to do with cellular immunity, not human immunity. And this presented to our audience a new concept, the exomes given with convalescent plasma, in addition to IgG, IgA, IgM, if you will. So that education is foremost in terms of what we're doing. Next week, we'll be talking about making the right code decision. I'm going to have an ethicist there, a gentleman who is a end-of-life specialist and hospice specialist. And we're talking about how difficult it is to be honest regarding a code status. If I have a person who's 95 years old, they've got hypoxemic respiratory failure, they're going to be put on the ventilator, their chances of survival are very slim. And how do we face that in terms of proper ethics, discussion with family? Usually we can't discuss that well with the individual because they're, if you will, delirious or altered by the illness itself or intubated. They've lost the ability to make personal decisions. But we've taken many, many aspects of COVID. For example, I had a slide deck today to show you what's new in terms of the cytokine crisis storm that occurs. And that's a real breakthrough because in Neufield Hospital in Oxford, they really, in May and June, showed the dexamethasone, which is very cheap, 6 milligrams either IV or PO daily for a period of upwards of 10 days, makes a difference. It cuts down the mortality on the ventilator by 30%. It cuts down the mortality of hypoxemic respiratory failure receiving oxygen by nasal prongs or mask, or by BiPAP, or by high flow nasal prong oxygen by 10%. That is the first real breakthrough, and it has to do with a very cheap medicine that's world available. And I'm very glad that in Oxford they picked something that's on the shelf, cheap, readily available, and we can use it. And the case I was going to give you to show you was a gentleman who came in. He was actually in Boise, Idaho. We were taking care of him from San Francisco, doing a consultation. He was near intubation, and we added steroids. We used an oil-filled approach, and his ferritin level went down, and his C-reactive protein level went down.
We can show slides now if you care to.
I'll do without them. It's all right. We'll just do without them.
Okay.
That's all right. Okay.
Yeah.
So we showed on this gentleman that his markers, all the markers really, the D-dimer, the C-reactive protein, the ferritin, those are the three markers. Probably the best is C-reactive protein. All the markers were improved within 2 or 3 days. The patient was not intubated. And this had to do with a breakthrough, which is a major world shared knowledge, a drug that is available on the shelf everywhere. And the education is to make sure that the doctor in Kathmandu, the doctor in Northern India, the doctor in Manila, the doctor in Shanghai, the doctor in Nigeria, they know this information, and that's solid information. You know, we use a scoring system. That is a 1B recommendation. It's an excellent recommendation. There's no other recommendation you can make for the treatment of COVID that is 1B. There's none. That's it. There is no antiviral proven mortality efficacy. Remdesivir does cut down the clinical course by about 4 days. You gain in that regard, but it costs $3,000. Who can afford that in the world? It has no mortality change. And if one could use it, one would, but it won't change mortality as far as we know. We have other presentations we've done, which are very important. We talked a whole session on proning. Proning goes way back to bronchiectasis, and the British are very good in this, and Brompton Hospital and so on. The value of something simple like proning, the turning a patient upside down, getting areas that are atelectatic to open up by gravity, is cheap, effective, difficult to do. On a ventilator, it's hard to prone a person, but you can do it with proper nursing, and it makes a big difference. I can't say it's shown any mortality difference. There's no study on that, but I can give case histories of improvement. And we talk about, I mentioned about the use of convalescent plasma. No data changes mortality. We're doing it in good faith, but there's no data on that. And there actually are, we made 100 questions that needed answering by excellent rounds, by grand rounds, if you will. And our goal is right now, every week, to take a different aspect of COVID-19, be it nausea and vomiting, be it lack of taste and smell, be it a heart attack, be it a stroke, be it hypercoagulable, be it the delirium that goes with it, whatever. But if you get close enough to COVID-19, it's like getting close enough to a keyhole. You see the world. You can see all diseases, if you will. But our emphasis is education based upon a case history every week, and we're getting this across the board to many, many countries. That's our goal. So number one was consultation, and I showed you the equipment we give for that right behind me. This is my study, by the way, near San Francisco. Number two is education. We're doing this every Wednesday. You're welcome to join us. These sessions are free, and by the way, we provide CME credit. Rotary provides free CME credit for anybody who wants to sign up for it. You can take care of your boards, your examinations, and so on by attending us. But number three is an EMR. To really do medicine properly, you need an electronic medical record, but they cost millions. They're very, very hard to form. We have an agreement. We're working with a company called MedWave, They have a very economical electronic medical record called Harmony MD. My goal is to give that EMR to every one of our hospitals. It's cloud-based, free when I can. I can't yet because it's not successful enough yet. But I'm on the board and I founded the company. And my goal is when and if we can, we're going to give that free because it's cloud-based with a do-it-yourself kit to every one of our hospitals, part of Global Offsite Care. So there's every reason to be part of Global Offsite Care. You get $5,000 of equipment. You get a grand rounds every week that has free CME. And if I have my druthers, you're going to get a free EMR. I'm in the Silicon Valley area. This is the area to develop that. We are doing it. If we can just have some success with the company, I will give that free. So this is exciting. The excitement is telemedicine is the medium by which we can bring consultation, education, and the EMR makes it all better. It makes it possible, if you will. You need to have a way of assembling your knowledge and having it stored and readily available. So I hope you'll bear with me. I enjoy giving a talk without slides, actually. So what I've tried to get across to you, I think you've got the message. Global Offsite Care, rotary-based, with 20 hospitals in the world. Telemedicine is our medium. We hope to really go to 200 hospitals or 2,000, if possible, with the help of Rotary. And we're going to do consultation, every hospital set up to do it, education, and I hope an EMR for every hospital. Okay, that's your slideless presentation. All right, okay. I'll turn this over for any questions.
Thank you, Dr. Good and Michael Cook. It was really very much inspiring for us. And this human factor is very important in telemedicine, and persistent believing in telemedicine and pushing that is really grateful.
Maybe another comment. I was in Nepal in November, this past November, okay? Yes. I was so impressed with your folks. You're like Hawaiians. You are, to me, such a nice Asian blend in terms of your humor and so forth. We helped start telemedicine in 6 hospitals. We gave them the equipment, $5,000 each, that's $30,000, okay? We were there to launch them and find physicians like Dr. Prakesh and Dr. Pradeep and Dr. Kaban and many, many others. Nepal is a great place, and I'm going to go back. I would have been back already, but I had to cancel my trip because of the travel restrictions. I've got a fine country.
Thank you. Thank you. You are most welcome. So if there are any questions, please.
So, Dr. Udaya, there is a question from Dr. Nishizawa from Bhutan through chat. If she can ask a question directly, it might be better.
Yes.
So,
please.
Dr. Nishizawa, can you turn on your video and the mic, and you can ask questions directly to him? Oh.
I'm very sorry that I have an appointment. I have to leave shortly, but I just wanted to find out if you could share the detailed specification of the device that you've shown to us, which will be very much helpful. So,
yeah, I'll tell you, I'll give you the parts on it.
Yeah.
This part is, you see right here, my hands on it. That's a KUBI, and you can buy that in Petaluma, California. And then this is a Samsung tablet. And this is a speaker that we put ourselves on it from the local shop. And this is a little microphone. We found that we could put this together far cheaper than buying any product. So we assemble this. It's less than $1,000, but this will enable you to do consultations in your country or in the world with a surety. And it functions. Usually we use Zoom in terms of the medium, but you can use others as well. But again, the entity we deal with is the hospital. It's not the rural physician. It's not the local medical society. It's not the university. We find a hospital that wants to join Global Offsite Care, and we give them this equipment, visit them, launch them, and they're part of our family.
Thank you so much, sir. Thank you so much, sir.
Thank you. Very good question. Thank you. By the way, I have great respect for Japan too. I was a professor at the University of Saga in 1991. I love Japan.
Thank you for mentioning that.
Thank you. Are there any queries?
It's
Yes.
Roger Strasser here. A very, very impressive work that you're doing, and seems to me consistent with my presentation around the potential for information and communication technology and the importance of supporting the local care providers. You mentioned that this is a Rotary Club initiative, and I'm wondering about the involvement of the local Rotary clubs, like in the different countries where you have your offsite global offsite activities, whether the local Rotary Club in those particular communities are also involved in that.
Great question. We always deal with the local Rotary Club. We visit it. We give a talk there. We ask them to watch the finances. For example, I work with other concerns. We tried to give money, for example, to Liberia and places like that. It disappeared. Just disappeared. But when I deal with Rotary, it doesn't. Rotary has fiscal integrity, and they are, they're like dealing with accountants. They're honest. They're service people. They're as good as any religion, as far as I'm concerned. And the service is a great religion in and of itself. So the reason our idea may work is Rotary. That's it. The local people who are the successes in the community, who want to help out, and are willing to back these things, because we're in and out. We leave, but Rotary Club stays there and has to back the hospital. But your question is absolutely on the nail's head.
Yep. All right.
So I'd like to proceed with my presentation. So today my presentation is National Telemedicine Guideline and COVID pandemic. So we all know about these opportunities of telemedicine. It has huge opportunities, but we always focus on the challenges of cost, network, electricity, and I think this human factor is very important. Software, this equipment, these are all challenges. So telemedicine, each country's unique laws and regulations are there. And these challenges are maybe because of those laws and regulations that are maybe difficult to implement. There are lack of resources to provide for the increased demand for healthcare services. And there is uneven distribution of geographical availability of these services worldwide. There are technological barriers, and changing the mindset of the people is also very important, I think. So, and progress is very slow. We know it is needed, but the development of telemedicine has been very, very slow. And I realized during this COVID pandemic, President of Nepal Medical Council, he called me and asked for a guideline to prepare a telemedicine guideline especially for medical practitioners in Nepal. and he gave me the time duration of only 2 weeks, because in pandemic, everyone wanted this guideline. And previously we were talking about guideline and regulations for years and no one was hearing, but when there is pandemic or disaster, then everyone wants this. So now, according to WHO, globally 58% of the surveyed countries are now using telemedicine, and 42% are among low-income countries. And only few countries have proper formal national guideline. And major issues we can see is medical, legal, and financial. Major things are like medical ethics, can you see the slide? Is it here?
No, we can't see the slide.
Okay. So Rosen is helping me to change the slide.
Could you put it on slideshow so we can see the whole slide, please?
So now you can see the slide.
We can see the slide, but your slide is still not moving.
Oh, it's not moving, yeah.
So you need to click enable editing in order to change
Maybe
it
you
to
might have to
slideshow.
enable that PPT.
See, enable editing at the top. Yeah, that's working sort of.
So sorry for the interruption. Next slide. Next. So this president of Nepal Medical Council, he asked me, and then I realized that everyone wants this telemedicine in disaster and epidemics or pandemics, and in normal days, maybe no one is that much interested in using this telemedicine. So next. According to WHO, 58% of the surveyed countries are using telemedicine, and 42% are among low-income nations. So, and about this national telemedicine guideline, only few countries had proper formal national guideline, and major issues were medical, legal, and financial. Like medical ethics in telemedicine, code of conduct, patient identification, healthcare professionals identification, patient confidentiality and secrecy of the data, data authorization, regulations, lawsuits, and in case of misconducts, data processing, documentation, e-prescription, electronic billing, reimbursement of telemedicine, and integration with the insurance system. These are the major challenges in telemedicine, and these are what I felt during forming the guideline. And in this COVID pandemic, use of telemedicine has increased hugely. In France, use of telemedicine services increased by 40%. And in Belgium, started reimbursing several telemedicine-based clinical procedures. In Germany, also, Health Innovation Hub published a list of trusted telemedicine services, resulting in a substantial increase in doctors interested in using telemedicine. And in NHS also, most of the UK's daily face-to-face primary care consultations were done remotely in the space of weeks during this pandemic. As Dr. Good also know, United States also has seen the most rapid growth of telemedicine. And the main thing was they changed this privacy law, and they could use FaceTime for telemedicine. 46% of the consumers are now using telehealth to replace canceled healthcare visits, while healthcare providers are seeing 50 to 175 times the number of patients via telehealth than they did before. So actually it was not planned. We all know COVID was not planned, and telemedicine in COVID was also not planned, but healthcare system substantially increased the use of telemedicine. The technology has been ready for years. We all have been using this telemedicine for years, but its widespread adoption has been slow, constrained by regulatory barriers and a resistance to change, long-established approaches to healthcare delivery. And US rolled back these restrictions on access to telemedicine and eased some privacy regulations to allow people to use platforms like Skype and FaceTime. This Department of Health and Human Service Office for Civil Rights also is using HIPAA enforcement discretion to temporarily allow physicians to use FaceTime, Skype. And EU also, they are sharing this health data sharing for common use, of course, maintaining the confidentiality of the patient. On one hand, teleconsultation will be possible even if healthcare professionals are carrying out the consultation, not the patient's referring physician. And on the second hand, it is no longer necessary that the teleconsultation be preceded by a prior in-person consultation with the healthcare professionals within 12 months period, especially in France. Teleconsultation is therefore no longer part of continuous healthcare pathway. So these regulations are being changed during this pandemic. Next. In India also, Ayush Mishra, he had a very heart-touching story to start this telemedicine and was trying to push telemedicine but for years, and he was not being able to. But the firm languished in a legal gray zone for years until the coronavirus crisis spurred the government into broadening regulatory approval for virtual consultations. Now he hopes to open hundreds of clinics around the country. And in March, they have also published National Telemedicine Guideline in India. In Singapore also, they were rigid to start telemedicine, like now they have started in non-telemedicine specific platform and loosening for data security and patient confidentiality, and also, of course, the protection obligation. Next. And without permanent changes to regulatory barriers, many of the valued telemedicine applications are being used today. If these regulatory changes are not made permanent, then they may be meaningless tomorrow. So we cannot afford to revert to previous restrictions on telemedicine. Doing so would be a major setback to the state of care and be met by consternation from healthcare professionals and patients alike. We must lift these restrictions to telemedicine permanently to enable better healthcare outcomes. So I think every country should have a telemedicine practice guideline suitable for its own country and people. It should be individualized, and even in the country, different parts can practice it differently. and regulations should be different, but it should be monitored. It should be regulated, of course. Proper training of the telemedicine service provider is a must. Without training, about these ethical issues, technical things, and privacy, data maintenance, documentation, these things must be trained to every providers. Ethical considerations and code of conduct would not be much different than traditional medical practice. Only that you can't touch the patient. There is no tactile sensations, and there are limitations of telemedicine. But considering the limitations of telemedicine, other ethical considerations and code of conduct should be almost similar. And issues like data security, interoperability, documentation, patient confidentiality will be dealt as the use of telemedicine increases. And we'll know more about telemedicine, we'll know more about the barriers. And like now, we can do e-banking very easily, mobile banking, online shopping. In bank also, we need, of course, data security, confidentiality, but we are very much confident in using mobile banking, e-banking. Then why not e-health? Next. So if telemedicine can work better in disaster, in epidemics and pandemics, then why not in normal? Why not in new normal? Or why not in continued normal? So I think we should continue telemedicine for betterment of the people, especially in the rural places, rural areas, remote areas. Thank you. Thank you for your patience and listening. So if there are inquiries, please.
Very nice. Very, very good.
It's Roger Strasser here. Excellent presentation, and I think you've highlighted some really a very important aspect of the experience with COVID-19 pandemic, which is that suddenly, in many ways, the whole world is meeting the way we're meeting today, using information communication technology. The use of telemedicine that was sort of poo-pooed and seen as sort of second class and not really justified, maybe unethical, all the things you said, suddenly is the way to do it. And I think, I mean, for people like me, and I think probably others who are part of this seminar, we've been meeting this way and using the communication technology capacity for many years, and now the rest of the world has joined us. And your last question, I think, is a key one about they these days talk about post-pandemic, the new normal, and how we can actually ensure that the good things that have come out of the experience of the pandemic actually continue to be part of the new normal into the future. So a great presentation. I have one particular question, comment question that you didn't, something you didn't cover, and that's about how it's paid for. I mentioned in Northern Ontario, the North Network, and now Ontario Telemedicine Network, a key to getting that started and making it work was a mechanism to pay the doctors who are involved, the referring doctor and the specialist who's providing the service, because that wasn't part of the regular system when it was new, and eventually became part of the regular system. And I'm talking about becoming part of the regular system about 15 years ago now in Ontario. But in many jurisdictions, and including in Australia as one example, payment of doctors to provide care using telemedicine, there was no payment, and so doctors didn't do it. Suddenly there is payment that the government has approved to support the lockdown, and now it's happening. You mentioned a 12-month rule. I think it was in France or Belgium or somewhere like that. In Australia, they have decided to have a 12-month it's only doctors who've had some contact with the patient within the last 12 months can actually charge for a telemedicine consultation. So in a sense, they're trying to sort of disincentivize doctors who are just trying to make money by talking to people on the phone type of thing. So I'm interested in how much you've taken into consideration the issue of how the services are actually paid for in implementing telemedicine and where that fits into your guidelines.
I mentioned something just about the United States. In March and April of 2019, the federal government of the United States paid $60 million into telemedicine. In March and April of 2000, $4 billion. Now that's a difference. That's an amazing difference. That was in the New York Times yesterday. And now one good thing that Trump does, I'm not sure he does many good things, but one good thing is that he is backing telemedicine to continue in terms of it being remunerated, because just like you're saying, Roger, the key is that doctors need to be paid to do it. Will they be paid after the pandemic? If they are, I think it'll continue. If they aren't, I think it'll wither.
So thank you. Thank you. We'd like to hear something from Bhutan, your experience on telemedicine and rural health. Kipchu. Kipchu. So would you like to say something, your experience from Bhutan? Yeah.
Hello, good morning. As such, we don't have any comments or feedbacks on telemedicine, as we are just attending the session organized by APN 50. And as well as on top of that, we have a presentation on telemedicine being attended by our doctors, and then which is being organized by Huisho University. And then sometimes we do attend the presentation organized by AIMS, and then some of the university from, it's related to APAN only. But as such, we don't have much experience on rural healthcare, because I'm ICT and engineer, local engineer from Bhutan. And then our focal person, Dr. Kipju Sring, is out of station. So as of now, we don't have any comments or feedback. So if any of our intern doctors have any comments or feedback, you can, as well our intern doctors also, they don't have any feedback or comments. Thank you.
Thank you. We would like to hear something from Myanmar.
Yeah, I was about to give some comments, especially on what Dr. Roger said about who is going to get paid for, how doctors are getting paid for. And coming from a private company, private organization running teleconsultation, that is actually how we are making our business model. As you can imagine, in a place like Myanmar, doctors really don't get paid at all. I mean, if doctors are working in a government hospitals or facilities, which most of the hospitals in Myanmar, especially out of places like Yangon or Mandalay, the main cities, mostly are government hospitals. And they really, the doctors don't get paid at all. So for them, it was a very welcoming sign that a private company was starting this telemedicine. And they actually are very eager to onboard into our platform and start telemedicine. So we started just in March. By now, we have onboarded almost 100 doctors into the platform. By the end of this year, we have an ambitious plan of onboarding almost 1,000 doctors. And then we are going to keep increasing. But as Dr. Uday earlier mentioned, the challenges are in regulations. We do not have any regulations as such in place. Even if, you know, developed nations are struggling with regulations, then you can imagine in a place like Myanmar, where even simpler regulations are not there. The complex regulations like telemedicine are even more hard to come by. But one of the encouraging signs that we are seeing is that because they see the value in the kind of work we are doing, so the government is engaging with us to see what could be the best practices and how we could form some sort of regulatory framework around telemedicine and telehealthcare. So that has been a very encouraging sign for us from for starting this.
Thank you. We are running out of time, and I would like to invite Mr. Anis from Tehran, who had joined late, and Arvind. Yeah, first Arvind.
Yes, hello.
Hello.
Can you hear me?
Yes, please introduce yourself.
Yeah, sure. Myself, Arvind Thakur, as a senior IT officer at Manmohan Memorial Medical College and Teaching Hospital located at Swambhu, Kathmandu. I'm working from since 7 years as an IT officer, and recently became a senior IT officer. Okay, and I look after telemedicine program, HIMS, Hospital Information Management Systems, and overall IT works. Also, I look after some administrative works like process work, operation of hospital, how hospital operates, from overall all those things. So that's it.
Thank you. Thank you. Mr. Anis from BPKHS, Tehran. Mr. Anis Bhatrai, are you there? And Mr. Dihan Marawaka.
Yeah, actually I am from, yeah, can you hear me?
Yes.
My internet connection is not good actually. Now I am doing my in Malaysia, but in Sri Lanka now this pandemic period, our staff actually did many treatment and support for the patient using this telemedicine. Actually, I joined this telemedicine kiosk university project at Hong Kong 2010, I think. Yeah. After that, continually, I am engaged with this, and not only me, actually many staff members now in Sri Lanka, many hospitals, especially the very remote hospital. The very first fully digitized hospital is a very far hospital in Sri Lanka, not the Colombo. Actually, because of our university members involved in, then the main problem is now having that some remote area hospitals having fully digitized system, but in main Colombo or these main hospitals, once the patient transferred to the main hospital, they are having still the manual system. So there are some problems. Actually, in Sri Lanka, at the moment, the telemedicine is more popularizing. Okay, thank you.
Thank you. So we are running out of time. So I think we should say goodbye to all.
Thank you.
Yeah.
Thank you for the opportunity.
Bye-bye.
Will we be able to get contact information for these guys?
Yes, please continue with our information sharing. Especially Dian, please, we'd like to hear from you and continue the contact with you.
Great.
Sorry, I didn't get you.
Fantastic.
Yeah. Dihan, please.
Great session. Thank you very much.
Yes.
Thank you so much. Good night. Bye-bye.